the big kind of elephant in the room, and already indirectly while we're talking about the local therapies, we mentioned two drugs, sorafenib, which we all know has been the standard of care for a long time, and we spoke also about lenvatinib. And there is no advance. But before we get to the new advance, tell us, Catherine, lenvatinib, what is it?
So lenvatinib is a tyrosine kinase inhibitor, a multi-kinase inhibitor, similar to sorafenib. It has a little bit more VEGF activity, and it was studied in the REFLECT trial where they looked at lenvatinib compared to sorafenib as a non-inferiority study, meaning they wanted to show non-inferiority. And the study was a positive study that showed that lenvatinib was non-inferior in terms of overall survival. Now, interestingly, in this study, the secondary endpoints of response rate was actually higher in the lenvatinib. So we do see a bit more response rate with lenvatinib. Because it also hits a little bit different TKIs, we do see a little different side effects where there's more hypertension with lenvatinib and less of the hand-foot skin reaction than we see with sorafenib. So there is a little bit of a difference between the therapies in that way as well.
Fair. So that's lenvatinib, and as we heard, it's a non-inferiority, but nonetheless with great outcome and improvement in progression-free survival and response rates. And by all means, it's a standard. But then, Anthony, for the last 3 days, every day I heard atezo-bev like almost every 5 minutes. What is it?
So this is based on the emerging results, and now we have a phase 3 study called IMbrave.
You are.
So this combination of atezolizumab and bevacizumab is based on the concept of concurrent inhibition of PD-1 from the immune therapy perspective and anti-VEGF therapy. This is based on actually good scientific evidence that anti-VEGF therapy not only changes the angiogenic milieu in the tumor, but it also has immunomodulatory effects, especially on myeloid-derived suppressor cells, macrophage balance, etc. So anti-VEGF therapy may actually synergize with anti-PD-1 therapy. So there are many combinations being studied in this space. But you asked about atezolizumab and bevacizumab because that has the most mature data at this point.
Yeah.
I guess from the end that we now have a phase 3 study that compared atezolizumab plus bevacizumab to sorafenib in first line, so previously untreated patients, all Child-Pugh-A. And in this study that was reported not long ago at ESMO Asia and now showed again at this meeting, there was a significant improvement in overall survival with this combination with a hazard ratio of 0.58. So a 42% reduction in the risk of death with atezolizumab, bevacizumab compared to sorafenib. Similarly, there was a statistically significant improvement in progression-free survival. We're talking about 7 months with atezolizumab, bevacizumab compared to close to 4 or so months with sorafenib. So all endpoints appear to be positive. The median overall survival has not been reached. The median follow-up on this study is a bit short, around 8 months. But nonetheless, this is a positive trial. It's the first positive trial in first line as a superiority study compared to sorafenib. And it's likely to change the standard of care in the near future.
Fair enough, and I totally agree with you. Even though the data for the survival is not totally out yet, because simply there is data, but simply people are doing extremely well on the atezo-bev, enough that's continued to linger in time, and we didn't cross a median, but it doesn't mean that it's going to be very good. So along that line, Ahmed, Monday you have clinic. Are you going to give atezo-bev?
So in general, we have to also weigh the risk-benefit ratio in terms of the side effects record of each combination and personalize your approach.
This is a patient who is like patient with Child-Pugh-A5, chip shot, perfect. Will you give atezo-bev?
Based on the data, of course, is very compelling. If you don't have a clinical trial option that could offer...
There's no clinical trial.
So it could be an option, of course, in patients who could manage and tolerate because it's a positive study, it's under review, so we expect it to be the new standard of care soon. It's going to also be very important for us as clinicians in future clinical trials. This is going to be the new control arm. So here you're raising the bar in terms of survival and response rate and so on. Also for combination strategies that we've been talking about, combining systemic and local therapy, this could also offer a very nice advantage because both drugs are IV and tolerable, especially even in patients with metastatic disease, because the cause of death is usually liver failure from liver tumor progression. So it's really gonna help all of us in the field to move it faster to the next level.
I hear, and you notice that I tried to really squeeze the situation as best as possible, because I definitely and always I respect the opinion of Dr. Kasib that as a scientist, he will definitely look at the data and analyze it and put it in perspective. But interestingly, the two drugs are available, and if anything, we have seen experience already patients that are getting the atezolizumab in the practice. And by all means, I would say, even while we're waiting for the maturation of the data, we are already seeing it in practice, understandably, because, of course, as Anthony summarized for us, the survival outcome and the overall the progression-free survival outcome are really quite impressive, let alone the response rate.